Welcome everyone to the May 27th, 2022 Washington Medical Commission business meeting. Excuse me, swallowing. Amelia, can you get our house in order?
Yes, thank you. Good morning and thank you for joining us for our business meeting. This business meeting is being recorded. The documents which will be discussed here today are available on the event calendar on our website, which is wmc.wa.gov. They are also available in the handout section of the webinar. I'm Amelia Boyd and I am the Program Manager for the Medical Commission. Jimmy Bush and I are the organizers for this meeting. Panelists, please be sure to mute yourself if you are not speaking. Attendees are automatically muted. Please note that anything posted to the chat or question section is considered public record. We will take public comment at this meeting. Once we get to that item, the chair, Mr. Malden, will read a script and will then ask for public comment. If you would like to comment, please use the raise your hand feature or add your questions to the questions box. Our time for public comment is limited and each speaker is likely to only have about 2 minutes to speak. And with that, I will hand it over to Mr. Malden for his chair report.
Thank you, Amelia. Sorry, looking for another piece of paper. So, chair report, I was going to talk about bylaws, but that's already on the agenda, so we will talk about that when we get there. I have one other item, and that is a plug for Frida Pace and for CMT sign up. Frida advises that from June 15th through the month of September, there are several vacancies that need to be filled to make sure we have a full house for each CMT presentation. And then Frida advises that from September through the end of the year, no one has signed up. So please check your calendars and see if you have time available and sign up accordingly. And if anyone has difficulty signing up, I'm going to offer Chris Waterman. He's always very helpful to me when I have difficulty signing up. So sorry, Chris, but someone may call upon you. That is it for the chair report. Consent agenda. We have a new item to add to the business meeting agenda today called future meetings, which we will talk about after the consent agenda. But the consent agenda does include approval of the April 15th, 2022 business meeting minutes and approval of the May 27th, 2022 business meeting agenda as amended. With that, I will call for a motion to adopt the consent agenda.
Move to adopt the consent agenda as modified.
Is there a second?
Second.
A second.
You, all in favor of adopting the consent agenda, signify by saying aye, or raise your
Aye.
hand.
Aye.
Aye.
Opposed? Hearing none, consent agenda is adopted. So there's not really a thought for new business, but we'll let Melanie talk about new business future meetings now.
Thank you. So today I want to give you some information, and then I'm going to ask for the commission to vote on a question that I will be posing to you after the discussion. So this past legislative session, the legislature passed a bill that allows an agency during the time that there has been a declaration of an emergency situation to hold the public portions of their meeting virtually for the public only. Currently, under the Open Public Meetings Act, the public portions of your meeting, such as the business meeting, the policy committee, rules hearings or workshops, we have to allow the public to attend. And if you are meeting in person, then, in a location, then under the current OPMA, we have to also provide that address and location for the public to attend those portions also in person. But because of this new bill and because of the situation that we are living under with the pandemic, it is now difficult for us to attest to the public's vaccination situation and to require them to be vaccinated because we don't have any jurisdiction over the public. So this new law allows agencies to determine that because we are unable to verify the public's vaccination status or require them to mask up in any way, shape, or form, to determine via a vote that it is not safe enough, reasonably safe enough to have the public attend in person. And so if an agency is able to, they can provide a virtual option for the public to attend their meetings. So we actually have the ability to provide this virtual option for the public to attend our meetings. And so I am asking you today to vote that the Washington Commission cannot hold the public portions of their meeting within reasonable safety, and to offer a virtual only option to the public in our future meetings. And again, we're going back to in-person meetings as of July. So that is why I am asking for you to vote on this today.
This is Jim, and I would move that.
Thank you.
Melanie,
Yes.
how does this affect folks who may not have access to internet or ability to go in virtually? How do we help that make it equitable?
We don't have we don't have to provide an in-person location. We can provide a virtual location, and if they are unable to attend, just like if a person didn't have a car and couldn't drive to our meetings, we have no responsibility to do that. We only have to offer the ability to attend either virtually. So I can't
And
help.
I will point out, just to answer that question, Melanie, anyone who wishes to attend virtually can go to any local library and get on and use their computers for free and get internet access that is faster than most people can get at their homes.
And
I just
and
want to make sure
also,
we're thinking about that.
This is Heather. Also, there's you have to also provide a phone-in option, so they can just call and listen as well. So you just need a phone, really.
Great, thanks, Heather. That's helpful. Thank you.
So does that mean in the future, if the emergency situation terminated, does that mean we still offer the public virtual, or this is only during this special period?
This is only during this special period. When the emergency situation is over, then we would go back to providing a location for the public because the safety issue would no longer be valid.
Got it. Thank you. I will second it.
Thank you.
Dr. Murphy, do you have a question?
No, I have a comment. COVID numbers are going up, and I thank the state for doing this to help protect us. In my area alone, in the last week, COVID numbers have gone up 24%. So, I mean, this is a temporary solution. It's a responsible way to protect the public and protect us, and I appreciate it. I'm all for it.
Thank you.
I heard a second. Is that correct?
Yes, I second it.
Thank you. Any further discussion? All in favor of the new future meeting process, signify by saying aye.
Aye.
And raise your hand, sorry. Opposed? Hearing none, future business process is adopted.
Thank you.
Moving on to old business, committee work group reports. The packet contains the committee and work group reports on page 15. Are there any additions or late additions to any of the work groups and committee chairs? Okay, hearing none. Whatever is written, and it is good. Rulemaking activities. Amelia?
Yes, just a reminder that there is a rules hearing today at 4 p.m. We do have a quorum. The hearing is about the opioid prescribing patient exemptions. So if you didn't sign up to attend, but you have time to attend, I would be happy to have you there. So thank you.
Thank you, Amelia. And that, okay. The next item is our bylaws. We spent a fair amount of time revising the bylaws, and I think I'd like to call on Micah, if you're prepared to have a discussion. Micah has been our historical expert as well as editor of the bylaws.
Sure. Thank you, Chair Malden. I don't know if I could say I'm the historical expert. I just happen to be the one that picked this particular project up, as it turns out, a few years ago.
Doesn't matter. You're called upon anyway.
Fair enough. Fair enough. So just to give historical context, this has been an ongoing project going back to the very end of Dr. Howe's term as chair. We were unable to get the substantive changes through, but we did agree to update all the names because back then the bylaws still referenced the Medical Quality Assurance Commission as opposed to the Washington Medical Commission nomenclature. So you as a body adopted those non-substantive changes in November of 2017. And due to things like the pandemic and children, there was a delay in bringing the more substantive changes forward. This has been reviewed by the executive committee, and it comes to you for consideration and review and comment. It may not be voted on at this meeting. So per the bylaws, the executive committee or a member of the commission may put forward to this floor during the business meeting changes to the bylaws, and they must be considered between a meeting, and so there must be one meeting space before there can be a vote. So the July meeting is the earliest that you can vote on this. So just giving you an idea of some of the substantive changes. Basically, they're drafted from the standpoint of someone that had to start off the WMC from scratch. What guidance would be needed? Changes under purpose and membership are examples of that. You know, what is the purpose of the medical commission? Who are the members? What can they do? One significant change to call your attention to is the renaming of the leadership structure to chair, vice chair, and officer at large. The intent is to clearly designate a leadership succession in the three positions while leaving the officer at large position open to more WMC members who may not necessarily wish to become chair but wish to be involved in leadership. There's updates to include panel L references and clarifying things like the type of majority required to take action. Throughout most of the document, it simply said majority, and it was unclear if it was simple or 2/3, supermajority, that kind of thing. So that where we could, we clarified every one of those instances. There was also some duplication or redundancy within the document with respect to how you can vote or the structure of a vote or quorums, as well as cleaning up the section where individuals could potentially disrupt a meeting. I will note that all of this, when we did verify some of the language, all of this exists within statute or rule to some extent with respect to the OPMA or the APA. So besides that, any edits or changes you may have, please email me the specific language that you would like considered so I can compile that and it can be discussed at the next meeting. Any questions?
That surprises me. I know you've all read it already. So you have another month to get back to Micah with any suggested changes. Claire?
I just want to clarify, is the document we have in our packet the whole document? Is that the best way to access it?
Yes.
Okay.
I don't know if we can send it out.
Two documents in your packet. The first one is track changes, and that can be difficult to read, but I wanted to make sure that you are aware of what the changes were. Then you have a clean version, which is with all of those changes accepted. So however you prefer to work as far as track changes or not, you can certainly work with either one of those documents.
Great, thanks.
Other questions or comments? Okay. Well, please send your observations, changes, suggested changes to Micah during the next month, and we'll vote on it in July, or have additional discussion and vote on it in July. Moving on to the public comment portion of the meeting. Amelia, do we have public members of it that have signed in?
Not at this time, no.
Doesn't matter. I'm going to read the comment script anyway. We will now begin the portion of the business meeting to take public comment. The purpose is to allow members of the public to directly address the commission on issues of public concern. Please refrain from providing comments on pending or open investigations or disciplinary cases. We will not be answering questions or responding. Staff will be available after the meeting to answer your questions. Please understand that although the time period for comment during the business meeting is limited, the public can attend and provide comment at commission committee meetings. Excuse me, the public can also contact staff during normal business hours. We welcome written comments as well. Each commenter, if any have arrived since I started, will have 2 minutes to speak. When you comment, please state your name and who you represent. This concludes the public comment portion of the meeting. I want to thank you for, again, you can provide comments at any time. Thank you. We'll move on to the policy committee report. Dr. Domino.
Hello. Well, we have 4 documents from the policy committee. The first document is on page 39 to 45 of your pamphlet that we had downloaded. And this one is a document called Informed Consent and Shared Decision Making. We saw this last time, thanks to Dr. Robertshue and Mr. Malden for putting this together. And then Dr. Small and Rick Line also made some changes in it. The most substantial change is located on page 6, dealing with special considerations for surgery or invasive procedures. And this deals with the issue if there is some unexpected operative findings at the time and how best to communicate it to the patient. And Dr. Roberts had added this, and then the committee made a few other changes. So overall, we approve this document. You can see here what it says is, I'm assuming you guys can read this too, but unexpected operative findings may be encountered during a procedure or surgery that require additional procedures for which there is no consent. If these findings are significant and the patient is under anesthesia, an attempt should be made to obtain consent from appropriate family members if that is either not appropriate or not possible. Surgical judgment justifying the necessity of the additional procedures for which there is no consent must be clearly documented. At the appropriate time following the procedure, the additional procedures performed and the rationale should be discussed with the patient. So that was the major change in the document. And again, we thought this was an outstanding document and approved it. Is there any discussion about this?
Karen, it's Chris. I'm looking at that last sentence and the rationale, maybe we should change should to shall.
That sounds fine with me. I'm not the prime English major here, so any comments about the
That's a
word
good idea.
shall?
Christine, I think that's a good idea because I think that's a good idea because requirement.
Yeah, I saw that this morning. You beat me to the punch, Christine.
So long as the patient regains consciousness?
I'm sorry?
No, no.
I just want to say I thought this was an amazing document. Thank you so much. I think it's really a useful piece of work. Thank you, everyone who worked on it.
Yeah, the word group did an outstanding job. Claire, I can barely see people because I have a very small computer, but Claire, you raised your hand.
I am. Good eyes there, Karen. I have a question for basically Dr. Roberts, which I thought of after our meeting yesterday. It seems way back when I had my surgical training that there was a conversation pre-op about if we find something unusual, how would you feel about us taking care of it while we're in surgery? And just a brief discussion about that. Does that still happen?
Yes and no. First of all, that particular way of phrasing it wouldn't work very well. What do you do if somebody says no and you get in and find a malignancy, and it would be a big operation, potentially lethal if you got there. I don't see how you can figure that something, you can say if we find something else, we'll take care of it if we can, but I'm not sure, it's not something that I would really go after. I really think this is a better way of managing it.
Okay.
I have seen some informed consent documents that do address that in a very brief way. But I agree that it's not a, it's a difficult thing, and I think people just kind of gloss over it. I don't know if it's anything that the surgeons really focus on preoperatively or not, but it's usually in a written document, at least the ones I've read.
There's also a big difference between saying, if I find something, I'm going to do something, and then doing an incidental appendectomy while you're there, and doing something which clearly has to be done. You injured a blood vessel, and that blood vessel has to be repaired. And in one of those cases, there is no justification for doing the incidental appendectomy. It merely adds risk. And to do a blanket coverage that says, I'll do whatever I want to when I'm in there, even if you have permission, it doesn't count. So I think you have to be really careful about, John's right. Many of the written consents have that in them. Nobody reads those consents because you need magnifying glasses to read them anyway. A lot of us do talk about, if we find something unexpected, we'll take care of it up to a point. But I also think that when we're talking about consents, we need to have a mechanism that's explicitly defined. What do we do if we find it? And that includes saying, why did you do what you did, and documenting it.
So can you legally have a signature that authorizes you to do unknown process ahead of time? I'm not sure that's legal.
I'm not sure.
Thanks.
I think that's a little bit of a gray. I'm sorry. I think that's a little bit of a gray area. In all my years of defending medical malpractice cases, I've never had one of those instances occur. I think people are glad that they don't have to go home and come back and have another surgery. They're happy to have everything taken care of on the one-stop shop.
And the legal standard is that the written consent with signature is only evidence of actual consent, but is not itself alone informed consent. It doesn't answer the question. It's only offered as evidence that there could have been informed consent.
This is Jim, and I just have a quick thought. I mean, there may be people who have religious or spiritual or other guidelines or thoughts or beliefs that may make it okay to do one thing but not another, and I think that's a complicating factor.
Jim, I think you're right, but if you go to the Jehovah's Witness thing, they will have said, no, I don't want to have a specific thing done under a specific circumstance. If you then do it anyway, it doesn't matter how much you try and justify it. That's not a consent. They haven't given you consent to do it. There may be other things that are out there also, but I think those are unusual exceptions rather than something that we need to include in a rulemaking process.
Any other discussion from anyone else or any of our other surgeons?
No, I agree with what Alden said, because we've lots of times in the op notes, there's an incidental finding, and it's clearly written. And if there's something done that's outside of that scope or egregious, it'll get pulled in most facilities for a peer review. And I have seen in charts Jehovah's Witnesses indicating, I don't want this, 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 or this when they come in. So, and that's also documented. So.
Any other discussion? So the policy committee recommended approval with the, and I think with the change of shall instead of should in the last sentence of that red paragraph. Do we need a second of this, or we can just do a vote? I always forget.
You can just do a vote because it went through the committee.
So we'll have a vote then. All in favor of adopting this policy with, again, the replacement.
Can I just make a quick, can I just ask a quick question before we vote? Sorry.
Sure, go right ahead.
I wonder if we want to think about the words family members. May not always be a family member, but you know, like a designated power of attorney or domestic partner or somebody.
We do have a section in here. It's one of the sections I think I added early on that deals with an incompetent patient and the necessity of having a representative, family member, or a power of attorney, or a court-appointed.
Right, but I realize that might be in a different section, but here it just says, if the patient's under anesthesia, an attempt should be made to obtain consent from appropriate family members. Well, I can tell you that when I'm in that situation as a surgeon, I don't always know who that appropriate family member is, and they may not be documented in the chart as to, you know, am I supposed to be calling a wife or a sister, or, and then even if I decide to call that person, the patient may not want me to talk to that family member. So it may be that rather than just saying a blanket statement of appropriate family member, then it may be from a either, I don't know how to word it, like patient approved designated representative or something like that to, you know, to make sure that it's somebody that the patient would have wanted. And also it may not necessarily be a family member.
I think that's a good point.
That's an okay change, Jimmy. I do think though, if there was a court-appointed representative of the patient, you would know that because that individual is going to sign the consent. But I agree, this particular paragraph doesn't address who that might be, or other than a family member. So,
Yeah,
change it to appropriate designated person. Because I agree, Jenny, that's a really good pickup, because a lot of people come in with their, you know, best friend or whoever, and that's a discussion that at least I always have, and even write their name and phone number like on the consent form so I can easily get to it. So who do you want me to talk to if something happens or at the end of the case, and who would I go to if there's a concern, or, you know, I think that's a really good pickup.
I agree. Thank you, Jimmy.
Do you guys like the word person or patient representative?
How about designated representative?
Yeah, that's a good one.
Representative would be, sounds good. Claire, do you have your hand up there too?
Yeah, the one area that I recall there being legal activity around has to do with children of like Jehovah's Witnesses that their parents may not want something done, but you feel it's important for the child, for the safety of the child. And that, at least the ones I know of that have come to court or gone to court, are we going to, do you think we should address that in this document at all, about parents of children and their consent.
Leave it to our surgeons. Dr. Roberts, you added this paragraph. I don't know what you think. It seems.
I recognize the issue. I don't know that we need to address it because that's going to you end up getting a consent on that anyway. Usually it's a court-ordered consent. You can do an emergency consent. I'm not sure how I would address that in this document anyway.
Aren't they a designated representative?
Right.
I mean,
I was just going to say,
Yeah.
isn't it in there? Because if you start broadening this, where do you stop? You lock yourself in with a policy.
And a lot of this is, there's a good bit of unsettled law on this too. Some of the specific things are answered, especially with the children, but I think we might be getting a little bit ultra vires if we start answering some of these things that the law itself is still unclear on.
Yeah, I agree. I think the less sometimes said in a policy, the better, because you lock yourself in if you're too defined. You know, regulatory bodies come in and they hold you to your policy. So, and every word in it.
But isn't that parent situation, would it include under the wording designated representative? Because parents can represent their, you know, underage children legally.
That's what I was thinking too. I thought we captured it in that.
Yeah, and I thought so as well. Any
I would
other?
say,
I agree. I agree.
I would say that, sorry, I didn't mean to talk on anybody, but I would say another way to interpret what Scott said is that we may be getting a little bit into the weeds.
Any other comments? So we have that change as well. I think that's an outstanding change. Thanks, Jimmy, for bringing that up.
Could I make one more comment?
Yes.
Kara, it seems like the wording from appropriate designated representative, I feel like the appropriate is maybe legally designated or appropriate, may not need appropriate. If it's designated representative, it would be legally designated.
The representative, it needs to be vague because it can either be legally or it can be somebody that the patient has said, this is who I want. It may be a friend, it may be a family member, it may be whoever. I don't think we should try and make that more restrictive.
Okay.
Hey, any other comments, Jim?
I'm sorry, one quick question. So from all what you said, are you saying that, because Jan Ling said maybe we don't need to have the word, you know, appropriate. Maybe we just need to have designated. And is that consistent with what you were saying, Alden, or?
Either. I don't mind the word appropriate designated because that may be something that is relatively assumed. If something bad happens in surgery, you may want to go out and talk to the husband, but haven't had a specific release to go do that. But that would be the appropriate person to do it in a certain situation. So I kind of like the word, but and that allows it to be a implied designated representative as opposed to specifically designated. So again, I think what we're trying to do is give an idea to people what to do in a situation where they encounter something they didn't expect. We're not trying to cover every possible mechanism that could trigger this.
Yeah.
This is, anyway.
Just
thanks,
thinking,
I agree.
thinking like a medical malpractice attorney, I would propose we get rid of the word designated and keep appropriate. That the word designated might tend to create law that we don't intend to create, with some creative plaintiff's attorney might make a big deal out of designated, and because designated seems to imply that there has been some type of formal designation or some stronger indication other than, well, this is the person who drove them there 40 times for visits, and I know of no other person that might be appropriate, even though it's not designated. I'm fine with the language as it is, but if we get rid of one of those words, I would vote for designated and leave appropriate there, because appropriate.
So what if instead of designated, we put patient representative, an appropriate patient representative?
I love it.
Or appropriate representative.
The reason I raised this whether remove appropriate is, to me, rating designated is more towards a legal term. Appropriate more towards a loose, designation. So it's kind of a, you have a both. One is more restricted, more loose. So that's why I wonder if you need or what the intention is. But I guess either way.
So the plan is to get rid of designated due to the legal implications and have patient representative.
No, I think it's appropriate representative.
Someone added patient, though.
Mhm.
Look at, that was mentioned.
I think it makes sense to put patient representative, because I mean, I don't want to split hairs or get too ridiculous, but yeah, appropriate representative could be, I guess, twisted into a way like appropriate hospital representative, appropriate legal representative, could be any kind of representative. So yeah, I mean, it makes sense to say appropriate patient representative.
Okay. Now with those changes, any other discussion? Any other changes? All right, ready to take our vote? All in favor, say aye or raise your hand. Anyone opposed to accepting this policy? All right, so that one we've approved. The second one is called medical professionalism. It's a guidance document. This is located on page 46 to 50 of the packet. And this one, the policy committee approved. There was a lot of discussion about items on page 3 over something that was added in there there you see if you go down to page 3 of this document. It was with the word state law, because and whether this was a state law or a rule, and what's involved there. And Heather was, I think Mike Farrell is not available today, but Heather was going to explain to us, since a lot of us didn't understand the nuances here about why we're listing state law there. Heather, can you explain it?
So there was just some questions last night about what state law this was and whether it was actually a law. So the law that is referenced here is actually one of the commission's rules, which is the Washington Administrative Code. And those are rules, agencies' rules in WAC are state law, just like a statute. They're enforceable. There are also other types of laws, but your rules are state law in Washington and enforceable against your practitioner. So just wanted to clear that up if there were any questions about it.
Yeah, thank you, Heather. There was quite a bit of discussion since we weren't clear about it yesterday, and I thought it's worth, before opening up, that this is strong language there. I think it is correct, as Heather said, and it explicitly points out issues that we've all been dealing with on the commission. And I don't know, Dr. Small, I think, was very involved in helping revise this. Thank you so much on that. Any discussion or comments about it?
Could I just ask a question about possibly removing the phrase in there, to meet the practitioner's personal or sexual needs? I can imagine a situation where it might be a situation where the patient is more attracted to the physician, and the practitioner should avoid those situations as well. It's not just about the practitioner's needs. You know, it should be a little bit more restrictive. Because the practitioners could just say, well, it wasn't me, you know, it was the patient.
So, Dr. Chung, where is that located over there? It's a little hard without that one right there. Good, thank you for us.
I've actually seen that exact instance come up. So I agree entirely. Good point, Dr. Chung.
Yeah, I think it's a good idea too. Anyone else have any comments about that or any other aspects of this? Again, I can't see.
I think given Dr. Chung's last two comments, we ought to nominate him for president.
Definitely so.
I respectfully decline.
So we'll remove that from the document. Yes, Melanie.
So that is a quote from the rule. It says regarding former patients. So it says, a physician shall not engage in any conduct described in section 2 above of this section with a former patient or a key third party if, and it lists a couple of things, but it says under B, uses or exploits privileged information or access to privileged information to meet the physician's personal or sexual needs. So that was taken right out of the WAC.
Melanie, do we have to have that there if we don't like it in this document?
I don't think you have to quote the WAC in this document, no, but it is in the WAC. So regardless of whether it's in this document, it is in the WAC. So, you know, it's just, so you have to look at that, but you don't have to quote it in this document.
It's time to change the WAC.
Why would you want to change the WAC?
I have a question for Christine Blake, because I think of you as being closer to the bylaws of the hospitals and the rules and regulations of the hospital than the rest of us. Do you use these documents in writing up the rules in your hospitals?
We make sure that we meet regulatory requirements, but we don't necessarily go word through WACs. But we do have a separate policy, at least in the Peace Health system, for providers that do something like this. So we follow policy.
Would you reference this document basically in writing them up or making sure they're no,
not necessarily.
I'm just wondering about how it's used, you know.
Yeah, well, what I do when we change, just personally because of my being on the commission, is when we get to the point where these are done and published, I actually share them with the whole system so that they're aware of what's going on, because not everybody, like we said the other day, reads all of these, and we get thousands and thousands of emails, and you're not always looking at newsletters that come out. So I do that, and it does make us take a little bit more notice of what's written, but it not necessarily do hospitals quote this when they put their policies together.
Okay, thanks.
So yeah, Dr. Small.
Yeah, so just thinking about that particular phrase that you were talking about, Jimmy. So uses or exploits privileged information. And again, keeping in mind the beginning of that sentence is about what state law prohibits. So state law does not prohibit using privileged information. All of us use it in order to provide patient care. So if we drop that phrase, I think that we need to explain what state law prohibits using or exploiting privileged information for, because otherwise that could inadvertently imply, if we just leave it hanging, that we can no longer use privileged information, period. And again, we all use that to provide appropriate patient care.
Yeah, excellent.
Well, it sounds like the sentence by saying it prohibits romantic or sexual relationships with former patients if the practitioner uses or exploits, etc. So it seems to me that within that context, that's what we're referring to.
Right, and this is regarding cases, and I know we've had several where a physician has looked up in the electronic medical records, not of one of their patients, but a patient, to get information, then to, you know, FaceTime or Facebook them or friend them or whatever. And so that's what this is covering. So that it's not covering just using the information in your normal course of business.
So what do people want to do? Continue to leave it as Dr. Chung recommended, or have the law, the statement, the words taken from the law? Is there any strong feeling of one way or another?
I think it's fine as it is. And the word personal, just if this were to ever get into a legal battle, the word personal would cover practitioners need to satisfy somebody else or meet their own altruistic desires. I mean, I think it's fine as it is.
I personally think the language is just fine, leave it as it.
Okay. Anyone against leaving it as it is now on this document? All right. So we had approved the document from the policy committee, and so we'll take a vote from the commission. All in favor, say, of approving it as it is there with the changes, say aye or raise your hand. And
Aye.
Anyone opposed? Okay, so that one's approved as well. The third document is called Practitioner Health, and I think this was a 4-year update of an existing policy. We read this last time, and thanks to Dr. Small for doing all these great suggestions on the document to update it and improve it. And so you see the changes there in the purple. We approved it as it was with these changes. Is there any discussion about it? Dr. Small, do you want to make any comments about the changes that you had suggested that were so great?
Thank you for that. I don't need to, but I'd be glad to answer any questions if there are any.
Any discussion of this document? No. So we had approved it with these changes. Can we take a vote on this? All in favor of approving it with the changes that were made, raise your hand or say aye.
Aye.
Anyone opposed? Don't see or anyone about that. Okay, and then the last document, which is also a 4-year update. This was on ownership of clinics by physician assistants. It was page 54 to 55. I think, Mr. Anderson, you were really involved in the initial writing of this, were you not? And we thought it was an excellent document. And actually, we approved it without making any changes. The things there in blue on the second page are referring to different state laws and documents, and those are just hyperlinks. They're not changes. So any discussion about it? Mr. Anderson, do you want to say anything about it?
I would just say bravo. Thank you. I'm glad the work held up, and thanks to the policy committee and everybody who supported this. So thank you.
Okay, so we approved it as is. Any further discussion? Yes, Dr. Romes. I don't hear you. Still don't hear you as well. I don't know if there anything, again, we can't hear you, your comments. So if you're the computer, I know we've been having certain issues with different medium with both hearing and visual things. So I suppose, is there a chat I'm assuming here. Perhaps if you're,
There is a chat, Dr. Domino, and it does show that Dr. Wones is self-muted on his end.
okay, so you're still, that could be your computer versus your microphone. Well, while Dr. Wilms is getting his computer to work, any other comments about this? I don't know if it's going to be difficult, whether we should have him call in. Mr. Malden, what do you think we should do? So we have his comments.
Well, I guess we don't know if he can hear us or see us or what's going on, but if somebody knows the phone number, maybe you could mention it now if he can hear us.
I thought he can because he raised his hand in response to a, you know, when I asked for any other comments.
Can he type them in the chat box or something, Amelia?
Yeah, that's what I was trying to see.
Yes, he can.
Or maybe somebody could call him.
What is the telephone number, Amelia?
So the telephone number is unique to each of you. So it's in his panelist email. If he received that,
He just gave,
it's at the very bottom.
he just gave the across the neck cut thing. So maybe that means he doesn't want to do it anymore. I don't.
I can't tell if that's yes or wait a minute. So
I took that as move along from.
Okay, well then we will. So I'm sorry, Dr. Wilms. We'll just do our vote. So the policy committee again accepted this, and so we'd like to take a vote from the rest of the commission. All in favor of accepting it, raise your hand or say aye. And then anyone opposed? And so we approve this then for another 4 years. Okay, so that's the end of the policy committee report.
Excuse me. Thank you, Dr. Domino. Move on to member reports. And I should say, Dr. Wellens, even though we've voted on this, if you have a comment, that's when you get connected.
Can you hear me now?
We can.
Oh, good. Yeah, I got a call from Scott and I was able to readjust things. Sorry for that. I thought it was interesting that there were physician assistants owning clinics employing physicians. I hadn't heard of that before, and I was just going to ask Mr. Anderson if he could tell us how common that was, really.
I think you're muted, Jim. It's catching.
I unmuted.
In the tradition, I was muted. So I went back and looked at a document that was ownership of clinics by PA's guidelines, which came out of the commission from myself and the other PA, and that was when Richard Brantner was the chair. And I think it's a good question, and the answer is there are very few, and I don't know if that means 10 or 5, but there are very few clinics that are owned by PAs, but there are some. And you know, the thing that we've heard frequently, or we heard back then, and we still hear, is like, well, what about the conflict of interest? How can a PA own a clinic, hire a physician to be the supervising physician, but to be the employer of the person who oversees them? In the document, this is from June 26, 2015. It's a guideline called Ownership of Clinics by Physician Assistants. It discusses this, and it talks about there are many situations like this in medicine. For example, most clinics and medical facilities are not owned by either PAs or by physicians or PAs, but instead by a variety of other organizations. And such organizations hire physicians to lead the medical practice, and it would clearly be an ethical breach for a facility to dictate medical practice to a medical employee, just as it would be an ethical violation for a PA owner to undermine the decision-making authority of the employed supervising physician. And it talks about the importance of ethics and ethical principles. So with that, I hope that addresses your question. And the answer is there are not very many. I don't know, but I'm guessing it's 10 or less.
Actually, Mr. Anderson, I'm going to pipe in. Jimmy Bush has given us some data from the demographics report stating that 2% of PAs report having an ownership interest in their clinic. Whether that's partial or total, it's unclear. But if you extrapolate that out from the 4,600 licensed PAs, we're talking at least 92.
But I think there's a distinction between a PA-owned clinic with a remote supervising physician as opposed to an employed physician in the same clinic that is owned by the PA. I think there's two different types.
And I do think the key, one of the key things you just said, Micah, is like that's unclear. Partial ownership, entire ownership. I mean, there's still a lot of gray area there. But thanks, I appreciate that data.
Yeah, most of the scenarios that we saw when this was being developed, as well as during the rulemaking for PAs back in, I believe, 2014 or 2013, came from PAs that were owning basically urgent cares in remote areas, and so that was where a lot of this discussion popped up. And they would address this issue not by employing the physician, but having them under contract as their supervisor. So there wasn't a strict review supervision or dual supervision scenario that was occurring.
Thank you.
Are there other comments or questions about Jim's excellent document?
I'd like to say I think this is an excellent document and addresses some of the stickier points. But one thing I was wondering, does it address in a large organization the clinic chief who has leadership responsibilities over the entire clinic, maybe a PA? They may be elected to those positions. So does it cover some of that as well? Where they may be actually writing the rules for how that clinic operates.
Arlene, feel free to jump in here too, because I know you've got a lot of clinical experience. But in my experience, I've never known of a PA-owned clinic where the PA was writing rules that govern the behavior of the physician who supervised them. And I've never seen that, and I've never heard of it, and I think that's a good thing, because I think doing so would further complicate the ethical implications.
Claire, with respect to your comment, that's a different situation because it would be unlikely that the PA would have sole responsibility for hiring or firing a physician, and would probably be unlikely to go in the face of other physicians to do some sort of a disciplinary action that was counter to what the other physicians wanted. That's less of a situation. That's not an ownership situation, and I think carries less risk.
Thanks, Alden.
Any additional comments, questions?
The clinic I worked with was owned by an outside party, and my supervising physician and I were both considered employees of that outside party. But I have interviewed PAs for PA school, and their objective was they already owned the clinic and they were getting their PA license after that so that they can be one of the PAs in their clinic. But beyond that, just getting into PA school, we didn't explore that. But I've only seen that in one instance, maybe two.
John, I have a question. What just hypothetical, if the PA who run a clinic got into trouble, would that automatically extend the investigation over the oversight having physician?
I think it would.
That's sort of a Mike Concannon question. That's sort of a joke for those of you who never met him. He was a former public member who was a really great member of the commission, and that's the question he would always ask, is like, what did the supervising physician know, and when did they know it? And so I think that's a good question, and it could. I mean, it certainly could. It's complex. I don't really think it's any more complex than a situation where a PA has a supervising physician in a clinic which is not owned by a PA. That's still always the question, because there's right now, although it's changing, but there still is a legal requirement for oversight and supervision by a physician for a PA. That's still a law, whether a PA owns the clinic or whether they don't. So I don't think the PA ownership really changes the expectation that if a PA is doing something and the supervising MD has no clue about what they're doing, then that's a concern, whether the PA owns the clinic or whether they don't.
Okay.
Any additional comments, questions? Okay, let's move on to member reports. Are there reports by?
Sorry, John, do we need to vote on that before you move on?
Didn't you already vote?
We already approved
Oh, we
it.
did.
Oh, we already did? Oh. Okay, all right, thanks.
I think we voted and then had a delayed discussion that we'll blame Dr. Wones for. So let's move on to member reports. Are there, I'm sorry.
I just have a comment, and it's a pleasure to work with you, John, and Dr. Robert, and Ms. Farrell on this informed consent policy, and I really appreciated the commission and the policy committee supported and refined it to make it into a fine documentation and guideline, and I hope this would help to improve patients' care and their satisfaction when this issue come up. So I just thank you for your efforts on this.
Thank you as well, Dr. Yu. You had a number of additions to the document that were very good. So thank you as well.
Thank you.
Are there additional member reports?
Can I just add something to the little interlude here between Yunling and John? Is that Yunling, I have, as like you, I'm in my 8th year. I'm just about done as soon as they get around to appointing somebody. And but in that time, I've just really come to appreciate your advocacy for patients, and you're always fighting to insert those insert the interests of the patient and the families in all of the discussions we have. So I really come to appreciate that. So my hat's off to you. Thank you.
Thank you, Jim. I will remember you when I got out of the commission, that all the interesting discussions, and I appreciate it. Also your comments and input. Thank you.
Are there other member reports or comments?
John, this is Bob, if I might. So on a somewhat different subject, outside of the commission, I'm currently serving on a state committee that's looking at behavioral health crisis intervention services across the state, and attempting to get some data on what types of crisis intervention services are available, areas where they're missing, and the committee's responsibility is actually to make a report to the legislature on this next year. If anyone has any thoughts about behavioral health crisis intervention services in terms of things that that you see in your communities that are missing, I'd certainly be glad to hear about those and take them to the committee. In parallel with this, and you all may be aware of this, the phone number for the National Suicide Prevention Hotline is being changed from its current 10-digit number to 988. The rollout is supposed to occur starting in July. Each state has to go through a process to implement that. Our state is actually probably ahead of most other states in terms of getting all the technology and changes in place to be able to accept the 988 number, but just thought I'd mention that in case folks aren't aware of it.
Thank you for that, Dr. Small. One last call for member reports. Let's move on to staff reports. The staff reports are documented on pages 56 through 63. Are there any late additions, changes? Micah?
Sure, just a couple. So in my report, I had mentioned the resolution that you all put forward. One failed and one passed. The one that passed was the digital credentialing one. It called for the creation of a work group to explore innovations and efficiencies in digital credentialing. That's basically using APIs to do digital handshakes between state medical boards and FSMB to speed up validation and verification processes. That I received my invitation to serve on that work group this week. So just as a FYI on that. I did want to call your attention to Ms. Jimmy Bush's staff report. She was the recipient of the Award of Merit at FSMB for all of her good work, and I did want to recognize her and call her out specifically for all the things that she does and with respect to research, reporting, quality assurance, audit, general queries, and just about anything else that we have a need for that is not in the disciplinary function, basically. So a big thanks to her and congratulations to her on winning that national award. And then finally, budget update. And well, yeah, you can go ahead and applaud for her because it was well deserved. So finally, budget update. I've been holding off on a budget update due to not being provided final control numbers or what are starting numbers for the biennium from the department, which is quite similar to flying blind. The joint operating agreement with the DOH specifies that we should get these from 45 days from the signature of the governor on the budget. Just for clarity, we received our control numbers for the budget passed in April 21 this past Wednesday. So not 45 days. While the blame for this cannot and should not fall entirely on the current fiscal staff, it is a systemic problem and it will be a subject of the discussion for the joint operating agreement renegotiations that start next month. So background control numbers are our overall budget minus any indirect charges taken by the agency in the form of, quote, management fees. With these, we can finalize our allotments and attempt to balance our budget with, again, quote, real numbers. As part of the provision of final control numbers this week, it was also revealed that we had been shorted in our spending authority to the tune of $578,000 for the biennium. This spending authority has been proactively applied to upcoming IT replacement costs and the salaries and benefit line items to correct allotment errors made by the fiscal office in past biennia. So basically, to balance out what we already have, they just put the allotment too low for what we had already been due. So just so you're aware, the total biennial control numbers for the Medical Commission are 18,365,520. The total agency indirect charges that we expect for the biennium are 5,063,423. Outlook is we are almost halfway through the budget cycle. Our monthly revenue continues to outpace expenditures, and we are growing back our reserves. Due to the pandemic-related spending reductions that appear to be winding down, I anticipate that expenditures such as travel and training will go to pre-pandemic levels, which provide more balance to the revenue versus expenditure equation. Overall, we appear to be underspent in the biennium to date by $700,000, which is roughly 4% under predicted expenditures. So this is an acceptable scenario to be in halfway through the budget cycle. But for those concerned, any unused funds at the end of the biennium revert back to our reserves. So we don't lose that if we don't spend it. Items of concern are IT costs for hardware, support, and supply chain. Those items remain closely watched, and our posture is one of proactive support for the staff. I just want to point out we do recognize that without quality hardware and software, our staff becomes far less able to do their jobs in our new distributed work model. So we have to be on top of that. The other costs related to the DOH service unit processing public disclosure requests. The biennial budget allotted for that service is $863,000. Last biennium, they overspent by more than $50,000, and they appear to be on track to turn those similar numbers in this biennium. The cost overruns and quality of work that we pay for are some of the primary reasons this will be a significant item in our joint operating agreement renegotiations. And again, those start next month. So the upcoming items that I wanted to put on your radar, and again, this is in the staff report, we did add staff during the pandemic to support license processing, and we will be submitting a decision package for your approval at the July meeting to send to the legislature. This will be for spending authority only, no additional staff, and it does not impact fees. That's all I have for my staff report. Thank you.
Thank you for that update, Micah. Additional staff updates? Amelia?
So I just wanted to let you know of a change that will be on all future agendas for the business meeting. We will need to move the public comment section to just after the chair report to get it taken care of before we do any business. So you'll see that in July.
Sounds like a good idea. Other staff reports? Okay, let's move on to the AAG report. Heather, do you have a report to make this month?
Yeah, just quickly to sort of follow on what Amelia was saying. So this past session, there was a pretty major bill that amended the Open Public Meetings Act. So some of the requirements have changed, and one of those is prior to this amendment, the Open Public Meetings Act only required that the public be able to view meetings or listen in. That has changed now, and there is a requirement that at every regular meeting, so your business meetings, regular meeting, the public be able to comment either orally or in writing prior to the meeting. So that's why we'll be moving up the public comment section to be at the very beginning, probably after the chair report, before any votes are taken, so that we can meet that new requirement. Thanks.
Thank you. Any additional staff? Oh, we're already past that, sorry. Moving on to the exciting part of the agenda, leadership elections. We have 3 individuals nominated for as new leadership. We have Dr. Jimmy Chung nominated for chair. We have Dr. Karen Domino nominated for chair-elect, and Dr. Terry Murphy nominated for vice chair. At this time, I'll also call for additional nominations from the floor as procedure dictates. I can't see everyone, so if you have a comment or have a nomination, please feel free to speak. Hearing none, we'll call for a vote of the election of the new leadership. All in favor of the new leadership as nominated, please signify by raising your hand or saying aye.
Aye.
Opposed? Hearing none, we have a newly elected leadership. Thank you.
Can we applaud?
You can.
That's great. That's great. Wonderful, wonderful choices. Congratulations all.
Okay. Moving on to the installation and a few comments by myself as the outgoing chair. So I've got a bunch of thank yous. So I want to recognize and thank the incredible commission staff and everything that they do. As chair, I had the opportunity to work with a number of folks that I would normally not have had a chance to work. So thank everybody, not just the ones I worked with, but thank all of the staff for all of the work that you do. And I'd like to also pay special recognition to Melanie for always being available at a moment's notice whenever I've had some issue to discuss. Some of those issues easy, some of them not so easy, but we were able to resolve most issues quickly. So thank you, Melanie. And I'd like to thank the dedicated commissioners who give their time to Washington patients to assure the delivery of safe, sound, quality care, and for the meaningful guidance to all licensees for the betterment of the medical profession in the delivery of quality medical care. Just absolutely incredible work, and I know that it's sometimes difficult for all of you to participate, but everyone seems to do their job and take their interest in the commission and the work at heart. So thank you. And lastly, I want to make a special thank you to Dr. Alden Roberts. Dr. Roberts was always available for advice and counsel, whether he was at home, on the road, out of town, or walking his dog. So thank you, Alden. I could not have done this work without you. So with those comments, the leadership is, thank you all for the waving hands. Moving on to remarks by the incoming chair. Dr. Chung?
Well, I actually didn't realize that I was going to be on the agenda, so I haven't prepared anything formal, but I do just want to, first of all, thank all of you and thank especially the leaders before me who, I really have, big, giant footsteps that I have to follow, and the guidance and advice that were given by those, who came before me, I think are extremely valuable and hopefully will guide me in my next phase in my medical commission career, I suppose. And I will certainly do my best to uphold the mission of the commission. I do want to just also point out that I think this is an especially exciting time for healthcare, the commission, and all of us. We have certainly extremely thoughtful, caring, and compassionate and dedicated folks on the commission. In my few years on the commission, I think I've really gotten to know some of the most amazing people. And, you know, I think the fact that this is essentially a volunteer position where you're, you know, putting in really a lot of time and energy into ensuring that the safety of the public and the integrity of our profession is protected. It just really, you know, I feel like I'm with just, you know, people of my kin who really care about, you know, not just doing my own job as a physician or a physician leader, but also, you know, coming together to make healthcare better for the people of the state. And as you all know, obviously, things in healthcare are different now. You know, COVID really, I think, changed how healthcare is visualized and seen by everyone in this in the world and in this country and in the state. That you know, the way policy and the quality of care and the stress that it has placed on our caregivers, changing care models, changing care reimbursement models, and changing health quality metrics. On top of that, where even before the pandemic, or maybe even through the pandemic, how healthcare is being consumed by patients and physicians, or I'm sorry, patients and the public. You know, healthcare information is becoming much more democratized. People can look things up. People can learn more about their health, and beyond just being sick and going to the hospital, now people are paying much more attention to their own well-being. You know, you can get data about your health at, you know, the click of a button or a tap on your watch. And you know, physicians are really challenged to, and physicians and PAs and other caregivers were really charged and challenged to keep up with that. And so I think we have a very exciting future ahead of us as you know, medical commissioners, in both how do we continue to uphold the integrity of our profession and protect the public, but at the same time look inwardly and say, how can the commission keep up with all these changes and make sure that that we are also pivoting and evolving as needed to ensure that we're doing the best that we can. And so I think, you know, the next few years are going to be extremely exciting, and I'm just looking forward to continuing to work with the great folks that we have on the commission now, and those who are going to be coming on board, and continuing to learn from all of you. I continue to learn from each and every one of you as we, you know, whenever we meet. So I appreciate that, and I really am thankful and welcome your support. So wish me luck. We're all in the boat together.
Thank you, Jimmy, for those comments. So lastly, I'd like to point out that my term doesn't end until June 30th, so I have plenty of time to work on my campaign to stop the steal. With that comment, meeting is adjourned. Thank you all.
Thank you, everyone.
Thank you.